Now, in cancer of the prostate, there was a very interesting study that was done some decades ago, actually, in which autopsies were performed on people of, I think the age was about 80, who had died for reasons not from cancer of the prostate. And some 80 or 90% of these individuals had detectable cancer of the prostate. If they'd been examined during a lifetime and these had been seen, they would have been properly surgically removed. Well, what does that mean? That means there's a lot of cancers of the prostate you shouldn't do anything with because intervention can have negative consequences. Now, there's another interesting way to look at it. If you look at the data and you say that people who are over 80, 90% of them have cancer of the prostate, and people who are 4 or 5% would have it, and intermediate ages, there'd be some intermediate number. So one way of looking at that is to say that it takes a long time for cancer of the prostate to become detectable. Another equally logical hypothesis is that getting cancer of the prostate increases your longevity. Now, we don't often think of cancer as a kind of beneficial thing, and I'll show you why I don't. However, something that's that common, that is under the influence of these polymorphisms, may have advantages. Now, we don't know what those might be, and the main reason we don't know is very few people look for them. However, one of the consequences of the relationship of disease susceptibility to these polymorphisms and the diseases occur in high frequency is that there may be beneficial effects. I'm sure that's not going to deter any of you from your pursuit of remedies for the cancers and other diseases, but I think that it's well to keep this biological possibility in mind, this concept of polymorphisms in which diseases that are affected by polymorphic traits are likely to have beneficial effects. The thing that we all learned in high school biology was the sickle cell trait and protection against falciparum malaria in young people. There was a balance in the advantages. Now, another point that I'd like to raise, and that's come up from time to time in our discussions so far, and today as well, is the issue of targeting cancer cells. Now, much of cancer therapy is based on the idea that there are cancer cells and there are normal cells, and we'd like to get a, quotation marks from 2 centuries ago, a magic bullet that only affects the cancer cells and doesn't affect normal cells. That hasn't happened. And the likelihood of that happening, I think, is small, based on prior experience. And a lot of that's due to the fact that cancer cells are our cells, and they're very similar to our normal cells. They're us. So a war on cancer means you're having a war on yourself. and you want to be cautious when you do that. So that constantly raises the issue of therapeutic index. And sadly, a lot of chemotherapy is based on very small advantages. There was a drug recently approved by the FDA, and there was a trial, a very well-designed trial, in which the therapy that was existing, if the treatment, survival after treatment, initiation of treatment after diagnosis, was about 9 months. And this new drug, which had every possibility of being a billion-dollar drug, increased life expectancy to 13 months. And drugs that have that level of improvement are considered to be highly successful cancer drugs. Now, if I suffered from one of those cancers, I think I would take that drug despite the minimal improvement, and there's always the hope that we'll get better and better, and that has happened. There's just been a recent survey that indicates there's been some successes. But treating cancer can be very difficult, and it's much better to prevent it. And also, it would be good to get therapies that aren't dependent on killing cancer cells and therefore killing normal cells. There's an attempt to do that, trying to get medications that affect the cancer genes. Gleevec is an example of how this may be the case. Gleevec works in a relatively small number of cancers, unfortunately. And then the possibility of altering the immune system, on the notion that there's a kind of immune surveillance. If you can kind of get that better, then the cancer will be under control. Well, again, those applications, there are some, but they haven't been overly dramatic. Now, I've worked on hepatitis B virus for many years, and we invented a vaccine that has been amazing, successful beyond my hopes. Since about 80% of cancer of the liver is due to hepatitis B virus, the vaccine program that's been in place for 20 years or so has now, has now shown a significant decrease in the incidence of cancer of the liver. So prevention of a cancer is far better than treatment. And the big successes in our campaign against cancer, and the war on cancer, you might say, has been a consequence of preventive methods. That's been the major improvement. It's been estimated some 20 or 30% of cancers are associated with viruses, and the number may be actually larger in the sense that viruses may have some role in addition to other etiologic agents. Nothing is ever caused by one thing. There are always multiple causes. Well, so this vaccination program has greatly reduced the number of cancers that have happened and that we can expect in the future. And there's another vaccine for papillomavirus that was introduced 3 years ago, and vaccination programs are starting now, have started for a few years now. And the hope is that that also will lead to a decrease in a very common cancer, cancer of the cervix and certain other cancers that are rare. And I think it's very valuable for cancer research institutes to spend more time looking at viral-caused cancers. Now, another aspect of this is that the people who get cancer of the liver are often infected about the time they're born, and they remain asymptomatic carriers of the hepatitis B virus for decades and develop cancer of the liver in their 40s, 50s, and 60s. So that means you have a 40, 50-year lead-up time when you can do something. Well, you don't want to start treating a kid the year he or she is born, or you want to delay it as long as you can, as a matter of fact. But there's now quite good evidence that if you lower the titer of the virus, you don't have to get rid of it. It's very hard to do that because the virus is integrated into the host's genome. But if you lower the titer to some sort of acceptable level that's been defined, you greatly decrease the risk that the individual will get cancer of the liver or chronic liver disease. My guess is that will prove to be true for papilloma infection, that is for people who did not receive the vaccine and go on to, and therefore have a risk of getting cancer of the cervix, or in the case of hepatitis, cancer of the liver. And it also means you don't need a very good drug, because if you have a drug that, or you can use a good drug in lower dose, and this is a totally different approach to the treatment of cancer. You're trying to deal with a virus or a virally infected cell and not use a therapy that has these unfortunate side effects by by attacking and killing normal cells.